Hello everyone. In this video on obstetrics, we will be continuing our discussion on abortion, and today we will be mostly talking about septic abortion. So, what is septic abortion? It is any abortion associated with clinical evidences of infection of the uterus and its content. So, although clinical criteria vary, the abortion is usually considered septic when there are the following criteria like the temperature, the rise of temperature of at least 100.4 degree Fahrenheit or 38 degree Celsius for 24 hours or more, and offensive or purulent vaginal discharge, and other evidence of pelvic infection like lower abdominal pain and tenderness. So if there is this thing, then we can say it is septic abortion, a clinical evidence of infection. And talking about incidence, it is difficult to work out, but for the overall incidence, but about 10% of abortion require hospital admission. 10% of abortion requiring admission to hospital are usually septic. The majority of septic abortion are associated with incomplete abortion, while in majority of cases the infection occur following illegal induced abortion, but the infection can occur even after the spontaneous abortion. Now, the talking about mode of action, the microorganism involved in the sepsis are usually those normally present in the vagina, that is endogenous, and the microorganism are anaerobic, like Bacteroides group of the organism like Bacteroides fragilis, anaerobic Streptococci, Clostridium wilsii, and the tetanus bacilli. These are the thing anaerobes, and the aerobes including the Escherichia coli, Klebsiella, Staphylococcus aureus, the Pseudomonas, the group A beta hemolytic streptococci, and methicillin resistant Staphylococcus aureus. Here the mixed polymicrobial infection is the more common. The increased association of the sepsis in unsafe induced abortion is due to the fact that the proper antiseptic and asepsis are not taken, incomplete evacuation, and inadvertent injury to the internal genital organ and the adjacent structure, particularly the bowels. So that's why in unsafe induced abortion, there occurs the septic, due to the lack of proper precaution and injury to organs. Talking about pathology, in the majority of cases, the organism are of the endogenous origin, and the infection is localized to the conceptus without any myometrial involvement. But in 15% of the cases, the infection either produces localized endomyometritis surrounded by a protective leukocytic barrier or spread into the parametrium, tubes, ovary, or pelvic peritoneum. In about 5%, there is generalized peritoneum and endotoxic shock. So what we have all just said, in 80% of the majority of cases, the organism are endogenous and infection is localized to the conceptus without myometrial involvement. In 15%, the infection either produce localized endomyometritis and or invade to parametrium, tube, and ovaries are spread, or in 5% cases there is generalized peritonitis and or endotoxic shock. Sorry for my handwriting and this all, okay. And talking about clinical feature, depending upon the severity and the extent of infection, the clinical picture varies widely, and the history of unsafe transmission by unauthorized person is mostly hidden by the patient. And the a clinical feature of septic abortion are the woman looks sick and anxious. The temperature is rise to more than 38 degrees Celsius with chills and rigor, and it suggests bacteremia. The persistent tachycardia of more than or equal to 90 beats per minute, it suggests spreading infection. There is hypothermia less than 36 degrees Celsius due to endotoxic shock. There is abdominal pain and chest pain. Respiratory rate is more than 20 per minute. There is tachypnea. There is impaired mental state. There is diarrhea, vomiting, the renal angle tenderness, and the pelvic examination shows the offensive purulent vaginal discharge, uterine tenderness, and the boggy feel in the pouch of Douglas. That is the pelvic abscess. Talking about the clinical grading of the septic abortion, in the grade 1, the infection is localized in uterus. This grading is important in the management part. The infection spread in grade 2. The infection spread beyond the uterus. Infection is spread beyond the uterus to the parametrium, tubes, ovaries, or pelvic peritoneum. In the grade 3, there is generalized peritonitis and or endotoxic shock, or jaundice, or acute renal failure. The grade 1 is most common, and it is usually associated with spontaneous abortion. Grade 3 is almost associated with illegal or illegal induced abortion. Now we will see the investigation. The routine investigation used are cervical or high vaginal swab taken prior to internal examination for the culture in the aerobic and anaerobic media to find out the dominant microorganism, the sensitivity of the microorganism to the antibiotic, the smear for gram stain. The gram negative organism isolated are E. coli, Pseudomonas bacteroides, etc. And the gram positive organism isolated are Staphylococci, anaerobic streptococci, group A beta hemolytic streptococci, MRSA, Clostridium welsii, Clostridium tetani, etc. And the blood is investigated for hemoglobin, total leukocyte count, differential leukocyte count, ABO group, and the RS grouping. The urine analysis including cortisol can be done. And the special investigation include ultrasonography of the pelvis and abdomen to detect the intrauterine retained product of conception, physometra, foreign body, intrauterine or intra-abdominal, free fluid in the peritoneal cavity or in the pouch of Douglas, that is a pelvic abscess. And we can do the blood culture if associated with the spell of chills and rigor. We can do the serum electrolyte, C-reactive protein, serum lactate as an adjunct to the management protocol of endotoxic shock. If serum lactate is more than or equal to 4 millimole per liter, it indicates tissue hypoperfusion. And coagulation profile, we can do the coagulation profile. We can do the plain X-ray for plain X-ray of the abdomen in suspected case of bowel injury, and the plain X-ray of chest for the cases with pulmonary complication like atelectasis. The immediate complication, most of the fatal complications are associated with illegally induced abortion of grade 3 type. The hemorrhage related to the abortion process and also due to injury inflicted during the interface. There can be injury may occur to the uterus and also the adjacent structure, particularly the bowels. And the spread of infection leads to the generalized peritonitis. The infection reaches through the uterine tube and the perforation of uterus, bursting of the microabscess in the uterine wall, and the injury to gut, and that causes generalized peritonitis. And the endotoxic shock mostly due to E. coli or Clostridium welsii infection. Acute renal failure, multiple factors are involved in producing patchy cortical necrosis or acute tubular necrosis. It is common in infection with Clostridium welsii. In the lungs, there is atelectasis and acute respiratory distress syndrome and the thrombophlebitis. And all these lead to increased maternal death, the magnitude of which is to extent about 20 to 25% as per hospital statistics. And the remote complications include chronic debility, chronic pelvic pain and backache, dyspareunia, ectopic pregnancy, and secondary infertility due to tubal blockage and emotional depression. For the prevention of this septic abortion, we have to boost up family planning acceptance in order to prevent the unwanted pregnancy. The rigid enforcement of legalized abortion in practice and to eliminate the prevalence of unsafe abortion. The education, motivation, and extension of the facilities are to be done, and to take antiseptic and aseptic precaution either during internal examination or during operation in spontaneous abortion. Talking about management part, firstly, the general management includes the things like hospitalization is essential for all cases of septic abortion. The patient is kept in isolation, and to take high vaginal or cervical swab for culture, drug sensitivity test, and gram stain. The vaginal examination is done to note the state of the abortion process and extension of the infection. Overall assessment of the case and the patient is labeled in accordance with the clinical grading. Investigation protocol are done, various investigation protocol, and the principle of management are to control sepsis, to remove the source of infection, to give supportive therapy to bring back the normal homeostatic and cellular metabolism, and to assess the response of the treatment. In the grade 1 grade 1, we have to do the treatment as the antibiotic use, analgesic, we have to give the analgesic and sedative as required, and we have to do blood transfusion is given to improve anemia and body resistance, and we have to do the evacuation uterus, as abortion is often incomplete. Evacuation should be performed at convenient time within 24 hours following antibiotic therapy. The excessive bleeding is of course an urgent indication for evacuation. Early emptying not only minimizes the risk of hemorrhage but also improves the 9 days of infection. The procedure should be gentle to avoid injury to uterus. Okay, and in grade 2 there is we do the drugs like antibiotic. Mixed infection include gram positive, gram negative, and aerobic anaerobic organism are common, and we have to give antibiotic. Ideal antibiotic regimen should cover all these organisms as we have previously listed. The antibiotic microbial therapies are like combination of either piperacillin or tazobactam or carbapenem plus clindamycin intravenous. This gives the broadest range of microbial coverage. Empirical therapy is covered first, and it is changed when the culture sensitivity report is available. We have the vancomycin or teicoplanin may be added for MRSA resistant to clindamycin. Gentamicin can be given when renal function is normal, and metronidazole covers anaerobes. The piperacillin, tazobactam, and carbapenem cover the most organisms except MRSA. So that was all. And analgesic sedative. Sorry, focus. Okay. Analgesic and ATS are given as in grade 1. Blood transfusion is more often needed than in grade 1 cases. The clinical monitoring to note the pulse, respiration, temperature, urinary output, and the progress of pain, tenderness, and mass in lower abdomen. And central venous pressure is greater than 8 mmHg. And so we have to do clinical monitoring. And in grade 2 we have to do surgery for like evacuation of uterus should be done early following an initial dose of antibiotic. We have to do posterior colpotomy when the infection is localized to the pouch of Douglas, and if pelvic abscess is formed. It is evidenced by the spiky rise of temperature, rectal tenesmus, frequent loose stool mixed with mucus, and boggy mass felt through the posterior fornix. Posterior colpotomy and drainage of the pus relieve the symptom and improve the general outlook of patient. So that was all. And in grade 3 antibiotic are used as we have already discussed, and the clinical monitoring is to be conducted as we have discussed in the grade 2. We have to do give supportive therapy is directed to treat generalized peritonitis by gastric suction and intravenous crystalloid infusion. Management of endotoxic shock or renal failure is, if present, is to be conducted as described already. And feature of organ dysfunction should be carefully guarded against. The patient may need ICU management also. And laparotomy, and the laparotomy indication for laparotomy are injury to uterus, suspected injury to bowel, presence of foreign body in abdomen, and unresponsive peritonitis suggestive of correction of pus, septic shock and oliguria not responding to conservatively, and uterus too big to be safely evacuated vaginally. The laparoscopy should be done by experienced surgeon with an skilled anesthetist. Removal of uterus should be done irrespective of parity. Adnexa is to be removed or preserved according to the pathology found. Through inspection of gut and omentum for evidence of any injury is mandatory. Even when nothing is found, for laparotomy, simple drainage of pus is effective. So we will discuss about what is unsafe abortion. The short part. Unsafe abortion is defined as a procedure of termination of unwanted pregnancy either by person lacking the necessary skill or in the environment lacking the minimal standard or both. About 90% of the unsafe abortion are in the developing countries, comprising 13% of all maternal death. All complications are preventable if it is performed safely with proper post-abortion care service. So thank you, and in next video we will talk about recurrent miscarriages. Thank you.